So now it's my pleasure to introduce our final keynote presenter, Dr. Jessica Corner. Dr. Corner is Dean of the Faculty of Health Sciences at the University of Southampton and has over 25 years of experience in higher education. She was one of the first students to graduate with a degree in nursing from London University and went on to specialize in cancer nursing at the Royal Marsden Hospital. Throughout her career, she's pursued a wide range of research interests that have focused on improving the care and support for people with cancer, combining academia, practice, and research. Please join me in welcoming Dr. Jessica Corner.
Well, thank you so much for having me. It's really great to be here. And it's a little difficult, though, being in the last slot with you. I know you've had a long week of concentrating a lot on research. So it's a bit hard thinking about how to keep your energy going at this point. So I'll try. But I was given the topic to talk about improving quality of care, the levers for knowledge, translation, utilisation, and that's quite a serious material-based subject. So you'll have to forgive me if I'm going to give you still quite a lot of content rather than only entertaining you in the last session. So, but what are my credentials for doing this? Well, as you've just heard, I've had a long track record in working between academia, research, and trying to improve the quality of care in cancer for people affected by the disease. A real passion for that. And I've worked in a number of settings. I've worked as a practitioner. I've worked as a professorial academic. I've also left that for a period of time and worked as a director for a major cancer charity in the UK that puts services in support of people throughout the country, which has taken me to work with government policy and on government committees and those sort of things. So I've wandered between the worlds of science, care, research, and actually what does it mean to try and get this implemented into practice. So that's going to be the subject of what I'm going to talk about. I'm going to do a little bit of the background of the thinking now around what it means to implement research and what are the challenges and issues around that. And then I'm going to also talk about 3 examples from my own research career of how I've worked with sort of fundamental questions into getting something into practice. And then I'll try and reflect on what I've learned along the way from that. So that's really where I'm going. So, what is the issue then? Well, there is a well-known gap between research and the problem of translating that into practice. This is a diagram taken from a very important report done in the UK by somebody called Sir David Cooksey, who was trying to explore, particularly around medical questions, what is the problem of getting that into the coalface, things into the coalface. And he came up with these ideas about these 2 translational gaps. The first one, which is getting basic research into sort of the clinical trial. So we're particularly thinking about medical devices, pharmaceuticals, those sort of things. But he also talked about the second translational gap, which is more pertinent to us. And this is about getting things actually into healthcare delivery, knowledge actually into the delivery, and says that actually that's the bigger translational gap, and it's bigger than the first, and not enough investment has been put into thinking about that stage of things. So what's the problem? Well, on average, it takes at least 10 years to get research findings actually implemented into practice, if at all. And from when we talk about drug discovery, typically that journey can be 20 years of investment or longer. So if we could shorten that time period, then huge improvements in quality of care could be achieved, especially if we just implemented what we already know. So for example, if you take issues around pain management, pain control, we know what we need to do. The problem is we don't do it. We don't do it in practice around things like pain management. So it's not that we necessarily need more research, actually. What we just need to do is do what we already know. And there's a final problem, and I think this is very pertinent to the nursing research community actually. Much research has no obvious application at all when you look at it. You can't see what the point of it was. And maybe we should challenge ourselves around actually undertaking research that at least has something that's worth doing and putting into practice and has an application to it. So there's something about developing impactful research. Now, again, in the UK, maybe different for you, but we've got something called the Research Excellence Framework. And this is where the process by which all universities across all subject disciplines are being assessed for the quality of their research. And at the end of this year, we're all having to put in all the papers we published and a big description around all the research that we've done. And it's going to be assessed by peers. It's a huge process, but it ranks all the universities in the UK one against each other. And nursing is part of this, and nursing is ranked actually amongst other disciplines, pharmacy, dentistry, allied health, midwifery, so forth. They're all being assessed together under this process. And for the first time in this process, they've put in a measure of impact as being a key component which will drive funding to universities. And by impact, it means, can you demonstrate this actually made a difference to people on the ground? And can you quantify that? And can you provide evidence that that happened? So for the first time, we're all actually having to say, what did we do that made a difference? So this is becoming very important. And if this is happening in the UK, you can be sure it's going to happen everywhere else. Funding bodies are going to be asking these questions. But what are the models about getting research findings into practice? There are a whole host of them. So I thought it might be quite useful to run through some of them and just talk about the limitations of some of our thinking on this. Evidence-based practice, and I've seen this term is being used a lot in the conference here this week. There's a lot of conversations and sessions around this, about getting research-based evidence, using research-based evidence as a means to facilitate clinical decision-making, and there's a whole methodology and process for doing this. But actually, evidence-based practice itself is coming under some criticism in terms of whether it is the only model by which research does get taken up into practice, and whether we need to think a little bit further about this. We've talked quite a lot about models of things like evidence and then how does it get transferred into practice. This idea that messages get pushed by the research producers to the users of research, and somehow there's a magic thing that happens that automatically users of research take it up and put it into practice. Well, that doesn't necessarily happen. And in fact, one of the issues around the evidence-based practice movement that is being questioned is that it has a hierarchy of evidence implicit in it that's based on a sort of biomedical set of principles that are really around clinical questions and interventions related to sort of biomedical practice. And it doesn't really take into account, because it favours, therefore, the randomised controlled trial, it doesn't really take into the fact that the kind of things that we do also need to consider social context, populations, cultures, organisational issues, and those kinds of dynamics. And evidence-based practice hasn't been particularly good at thinking around some of those more contextual issues. Other models have been about knowledge transfer and then exchange, which says that it isn't just okay to push findings out. We need to think about the mode by which we need to exchange the conversations. It needs interaction between people, between coalface practitioners, policymakers, stakeholders, funders of services, and those sort of things, to actually interact with researchers, to actually make sure that knowledge is transferred. And without doing that and adapting the research cycle to things like real-world context and timelines, and making sure that results are timely to policymakers, then that exchange isn't going to happen. You had Brendan McCormack, didn't you, at the beginning of the week, giving you what I imagine was a sort of lively session on practice development, perhaps, as a means of getting evidence-based practice into the nursing practice environment, and the need to do this kind of reflective cycle on what's the problem, what do you need to do, what evidence is there to change practice, and how do you then embed that. That's been a very useful model. We in the UK have also had something called the Medical Research Council Framework for the Development of Complex Interventions. This says you need to go through a number of stages by which you develop any new process for care, system for care, or intervention in care, given that this is a very complex thing to do, and go through a cycle of looking at developing that, both from the evidence, but modelling the way it might get used in practice, making sure you do feasibility work before going out into a full-scale evaluation, and then think about a phase of implementation so that the results of that is part of, and putting it into practice is part of that process. And then another model I wanted to just talk to you about is in terms of this very interesting paper from Millbank Quarterly on complex public health interventions, and actually needing to think about the very nature of what you might be doing before setting out on the journey of setting up a research project or an evaluation, and consider what you would call decision makers or policy makers' needs for this before you set out on the journey, answering these 5 questions to be sure that what you're doing is actually going to be relevant and timely, or actually conduct an evaluation that's going to sort of fit with thinking around what needs to be done. Is it even going to be practical to do the evaluation? And have you got the time to deliver it so that decision makers haven't moved on and made a decision before your results are even out, which quite often happens, doesn't it? So answering these 5 questions, very important. In the UK, we're now talking a lot more about the diffusion of innovation rather than evidence-based practice, evidence-based medicine or that. We're talking about how the process of uptake of new and innovative practices and changes to the health system might happen. And talking about the complexity of this process. Unless you understand the context in which these innovations get put into practice, the barriers to diffusion and uptake, the way that individuals within the system kind of work against this and aren't ready necessarily to adopt, how the way they need motivating, individuals' systems need motivating and the skills to take this up. And you understand this is a very complex process. Again, it won't happen. This is Tricia Greenhalgh's work here, which might be interesting to you. A very comprehensive review of the literature on this subject. And also, and again at University of Southampton, we have got now a centre for implementation science where we have world-leading thinkers on the subject of what it takes to get things implemented into the health system and practice. And a colleague of mine, Professor Carl May, has developed a theory about this called normalization process theory. And this talks about the work of individuals, health professionals and so on, in thinking about how to get research-based evidence taken up into practice. That healthcare professionals have to make sense of new innovations. They have to engage in it and work out how to fit it into their practice, their protocols, their care pathways. They have to collectively work on that. And they have to then understand it and sort of mould it and shape it. So it might not end up quite like the researcher intended it to look by the time they finish that process. But unless you let that happen, it isn't going to get integrated into the healthcare world. And this has been particularly looked at in relation to the take-up of new healthcare technologies like telehealth, telemedicine, those sort of technologies, that unless this sort of work goes on, the technology just gets left behind and actually isn't used. So this is very interesting. So, having looked at the sort of thinking and the different models available to us in relation to implementing research into practice and the levers for it, I thought it would be useful to take you through my own examples. So the first example is a whole program of work that I did from the mid-1990s on looking at how to improve the quality of care for people with lung cancer. This predated the Medical Research Council complex intervention model, pretty much predated evidence-based medicine, actually. That was just beginning to develop at that time and so forth. So when we started out our approach to this, we were doing this in advance of having things like these models available to us. But what we wanted to do, and this was a nursing approach, was to think about the problems that people face with lung cancer. Still a disease that's very challenging, that people don't live very long with, major problems with symptoms. 80% of patients experience the problem of breathlessness, and at the time, really no effective intervention for that problem. And the palliative care community reaching for things like morphine as the only route really to relieve suffering with breathlessness. And we wanted to do something about this. So we set out and worked on a whole program of research, starting from first principles of working through the problem through to full-scale multi-center randomized controlled trial and a knowledge transfer model. So we started by using people with the problem as our laboratory, to use a sort of biomedical analogy. We went out to them, we asked them what the problem was, and we talked to them in detail about what the experience of having this symptom was. And from that, we began to develop nursing intervention, nursing strategies to help people sort of self-manage that problem from themselves without using drug intervention. So no more, we put aside the morphine and we started working with our own therapeutic abilities as nurses, teaching people breathing retraining techniques, exploring the meaning of the symptom, helping dispel fears, giving them strategies to work with this. So we did that in an observational clinical setting, and then so having developed a model, we set up a nurse-led clinic to work with patients with the problem, and started off with a small-scale pilot study to test the model, and discovered it had a dramatic beneficial impact. Those patients that had the intervention were significantly better off than those that hadn't. Even though all of the patients were at the very end of their lives, they were very much palliative. It was dramatic, and it was published in the Journal of Palliative Medicine very quickly. So from that, we went on then to say, could we translate that into the hands of nurse specialists working in 6 centres around England? And we conducted a multi-centre clinical trial, randomised controlled trial, asking them to set up clinics, take the same approach, learn from us. And we set out with quite a political agenda, because this was a controversial new care approach that hadn't been accepted by the medical community, because it seemed heretic that you would do nursing intervention of this kind for such a major, difficult problem. So we thought we better do the gold standard trial. We did. We had an aim of getting it published in the British Medical Journal afterwards. And fortunately, we managed to do that. We completed the trial, showed very significant benefit for the patients who had the intervention compared with the control group. And it was published in the British Medical Journal and is still cited now around the world, actually, for management of breathlessness. Then we needed to think about translation. So we decided to adopt a non-commercial model. The idea was to speed and facilitate diffusion and uptake through a practice development program. We set up centres to be able to disseminate the techniques from us, trained other people, asked them to train others, and so forth. Then we found that that wasn't enough. People were asking for some kind of formal training, nurses were. So we set up an education program in a university-based setup. Then we found that wasn't enough, because we still couldn't cover the ground and make sure this was going to diffuse fast and effectively across all practice. So then we set up community of interest networks and try to diffuse it that way. And that was becoming very effective. We were delighted that our work got recognised in national guidelines. We have our National Institute for Clinical Excellence in Scotland, same thing happened. It's actually picked up by American Cancer Society recommendations too, so it's gone international. So we did quite well. This is now actually, I would say, embedded usual practice, these therapeutic interventions in lung cancer. But what did we learn from that process of having to sort of learn along the way about how to get new interventions based on nursing practice into practice? Well, the process of this was long. Even though we had used all these techniques, it was 10 years from concept to guidance, 10-year journey, actually, if you measured it in time. So that wasn't too bad. Publication in the top journal certainly supported translation and continues to do that. Working with practitioners about the issues of implementation was key, and translation needed to be multi-layered. New techniques needed to be learnt and mastered by nurses. It needed new roles, clinics, nurses to identify with it, develop confidence. It was a new context in which practice was being placed, and that needed development too. It involved shifting the paradigm of lung cancer management and palliative care from one of thinking this was heretic and ridiculous to thinking it being possible and something we should do in usual practice. And the interesting final thing about full embedding to occur was we, as the originators of the research and the practice, had to let go of it. I found that people were coming to us thinking that we were the experts and that they could only do it if they'd learnt it from us. So we decided to stop doing that anymore and stepped away from the practice because we felt we were hindering translation by this idea of nurses thinking you had to learn it from the foot of the expert, when actually these are simple techniques, really, and we needed to let go of saying that they had to be done in a particular way. So that was interesting. Second example is about how to get new ideas taken up by policymakers, or I think you might use the term decision makers. And this is about harnessing a participatory model of research to shift the context of cancer management. Now, in this project, we used and worked with people who had had cancer themselves to become co-researchers with us. We trained this group of wonderful people to become researchers. They all had had cancer themselves, either had it or had been cured for it or were living with it. And we wanted to do a study about what were the priorities of people with the disease themselves for research, thinking that would be a good route to influencing the research agenda and the policy decision-making agenda. So they became the lead researchers with us. We supported them to do it. And we wanted to think about this as a mechanism for influencing the direction of cancer research. We used a focus group approach, 12 consultation groups across all of the UK. We also did further focus groups looking at hard-to-reach groups, including people at the end of life, people from black and minority ethnic communities, and older people. And the very interesting thing about the priorities that came out of this consultation process, led by people affected by cancer themselves, was a completely counterintuitive ranking of priorities for research came out of this. So instead of it being, I want my disease researched, I want science done, I want early detection done, the first priority identified through this process was the impact on my life of having cancer and how to live with it, was what these people said. This was unexpected, and it was presented back to the research funding community and had an enormous impact, actually, on health policy and research funding strategy and these sort of things after that, and has directly led to the England and now all UK National Cancer Survivorship Initiative, because for the first time, people with cancer themselves had said their priority was to looking what it was like to live with this condition long term. And so there was something here about changing the way you do research in terms of getting things to happen. So what do we learn from this one? Well, calling it research actually slowed it down initially, because we then had to go through all sorts of permissions processes, ethics and all these sort of things to be allowed to do this. And it was very challenging for the ethics committees to think that it was safe for people who had cancer to be researchers and lead research. So we had to go through that process about 3 times to get permission to do this complex study. But the power of the service user voice to stimulate the take-up of ideas and knowledge transfer created the conditions for what has become a major cultural shift in thinking about the context, health policy, and what should be looked at. So it was very powerful and a mechanism that I suggest to you, you might think about using. The third example I'm going to talk about is a current one, which is in the context of the National Cancer Survivorship Initiative, where we're developing and testing new models of aftercare for people with cancer, how they're supported and followed up beyond their cancer treatment to live well with their disease. We've developed a framework for supporting self-management with cancer, rather than this being about disease surveillance, where you go to see your doctor, you have tests and investigations to make sure that the cancer isn't coming back. We're stopping that, other than essential surveillance, and in its place putting in an aftercare model, which is about supporting people to manage the condition for themselves. And we need to train health professionals to know how to do this and work with this kind of model. And we're doing a very in-depth evaluation of this complex change, asking one hospital environment with all the clinicians to let go of their surveillance-based follow-up model, where they see people forever, bring them back into clinics, make them wait for hours, see a doctor for about 5 minutes, having had a few tests, and then say, you're fine, go away, when they've actually got a long list of symptom burden, anxieties, emotional problems, return to work issues, long list of problems that nobody ever addresses. So we've asked the environment to completely change this model and move towards a self-management approach. And we've used a sort of diffusion of innovation approach, and using some of that normalization process theory, some of those thinking, to think about how to do this. And we needed to, first of all, think about, well, what proportion of patients are safe to put into this sort of self-care model? What ones actually still need to be thought of as complex cases that might need quite a lot of monitoring? So we had to look at, with the clinicians, what they would agree to do. So this was the proportion of patients that might be safe to go into which aspect of care. So that was one thing we need to do. We need to develop the technology on which all the monitoring of the patients through their actual tests, their surveillance tests, would happen. So that was all safe. So they did get called in for their tests and investigations, and doctors would feel comfortable that that was going on for safety's sake. And we needed to put in place a new care package and model. So it means changing their technology for their care monitoring, changing the practice of doctors, nurses, clinicians, and so forth. Very difficult, challenging work to do. And so we are then evaluating it and trying to do this as service evaluation rather than necessarily specifically research, to answer some of these rather different questions than whether it was only effective. And using a complex pre-change, looking at cohort of patients going through the traditional model of service before we did the change, and then a post-change evaluation using quality of life measures and a whole host of things, as well as looking at the process of change as experienced by the clinicians, the professions, the organisation, the commissioners for healthcare, and so forth, and also doing a cost evaluation of that. So we're nearly at the end of this. The final data will be in the autumn, so I can't tell you the answer, but I can tell you some of the things we've learned from this one. What have we learned? Well, we need to think a lot about the setting that you choose to do something quite as demanding as this. It's got to be very ready for change, and it's got to have champions of that change and a commitment to the change process embedded within it. Now, we had some of those things in place in this environment that we worked in, but not all of it. And the fact that the our health service is under constant change and pressure gets in the way of trying to make some of these things. The change process as well as so not just the research process, the evaluation process needs resource, but the process of change itself needs substantial resource. So in this change process, we had a significant experienced change project manager leading the change, supporting the clinicians to get to meetings, look at care protocols, making sure the IT could be changed and so forth. Very difficult. So we put in resource to support all of that, not just the evaluation. And it's very hard work. It took 2 to 3 years to make this whole thing go to the point that we say, we've done this. So you need to evaluate the change carefully at the right time. It's no good doing it too early, otherwise you miss any benefit of that change. So 2 to 3 years afterwards. And funding bodies need to commit funding and resource to support the knowledge transfer, the embedding of innovation, and they need to be very patient about the process of adoption and embedding that needs to happen, and we need to help them learn that they need to do that, which was something we needed to do. So I think I've given you some learnings across 3 examples of research that I've done over my career. What can we conclude from all of this that you might want to reflect on? Well, fully embedding research into practice so that it has real impact is very complex. And we need to be more thoughtful about that end-to-end process than perhaps we have done. And we've got a duty as researchers to be responsible not just for the first bit, the research bit, but for the whole embedding process, I think, and be mindful of that. It means designing what we do to be impactful. It means supporting and resourcing that change process and thinking about it from the outset. You need to design that into your projects from the beginning. And research with impact is more likely if the end user or setting that it's for shapes research with you, and it's developed around a need that they express to you, like those people with cancer. They express their need, and once we work with their need, the system started changing rapidly in response to them. Real impact comes with full participation with those that shape or determine the context in which the research is used. And you have to think about normalizing and embedding research findings as integral to the work from design to dissemination. So we need to stop thinking just simply about knowledge transfer as if it happens. We need to do something much more sophisticated than that. And I would say sustainable change that is there long after you walk away from your project or improvement is a design imperative, and one that we really have a responsibility to take on board in our thinking. Thank you very much.